Kavita Oberoi, founder and managing director of Oberoi Consulting. Enhanced heart failure is provided as a service to medicine by Servier Laboratories Limited. The key objective of the Enhanced Heart Failure Service is to support CCGs and the NHS to implement national and local guidelines to optimise heart failure care in the community. The key elements of the Enhanced Heart Failure Service are clinical audit, embedding of protocols and benchmarking. So the clinical audit aspect of the Enhanced Heart Failure Service analyses the current performance of GP practices with current heart failure management and produces a gap analysis. The embedded protocols help GPs during a consultation with a heart failure patient to ensure patient care and management is optimised. The benchmarking element of the Enhanced Heart Failure Service allows GP practices to measure their performance versus their peer groups. Through effective implementation of the Enhanced Heart Failure Service, we will see an optimised care for patients, which in turn means better outcomes and reduced costs for the NHS.
Hi, my name is Greg Fell. I'm a consultant in public health and I work for Bradford Council, but work principally with the NHS. So the current burden of heart failure across the UK is significant. About 900,000 patients are diagnosed with heart failure. It represents about 1 million bed days across the UK and 5% of all emergency admissions. The future is important and what will happen in the future is clearly difficult to predict. What we do know will happen is that we will have an ageing population and more older people. In the 20-year time period, we expect the proportion of the number of people aged 80 or more to double. Clearly, remember, heart failure is a disease of age. Also, more people are surviving heart attacks. That's a good thing, but heart failure, one of the risk factors is previous heart attack. So clearly those two things together mean we will have more heart failure, not less, in the future. In Bradford District CCG, the current cost of heart failure is in the region of £2 million in terms of monetary terms, and that's in about 800 patients, 820 patients. As per everywhere else, it's age related. Again, as per everywhere else, we think there's about a million bed days nationally. That translates to about 10,000 locally, which is a significant number of bed days. And again, about 5% of all non-elective admissions are on account of heart failure. So in terms of optimising the medical management of patients with heart failure, we know from the work that we've done to date that half of patients who have heart failure have optimal management in primary care. We know that can be improved, and we would estimate that by improving from 50% to 100%, the CCG would save about £1 million. And that would be a net saving. Clearly, there's some cost in terms of doing the optimisation, but that would be a net saving of £1 million. And you know that times are hard in the NHS, and £1 million is a significant chunk of money. If we implement the Enhanced Heart Failure Service across the CCG, we would expect to see significant amount of audit and benchmarking being done across the primary care practices, which is important. We would expect to see a significant number of patients being moved from suboptimal management of heart failure to optimal management of heart failure. That has a net financial return, as we've discussed, but from a patient perspective, which is equally, and some would say more important, we would expect to see people living longer. That's important. We'd expect to see improved quality of life in those patients who have improved management of their heart failure. And really importantly, we'd expect those patients to spend less time in hospital, which I think is the point.
I'm Dr. Matt Fay. I'm a GP based at Westcliff Medical Practice in Shipley, West Yorkshire, and I've been working with Oberoi Consulting to develop the Enhanced Heart Failure Service to optimise the management of patients with heart failure presenting in primary care. Heart failure is a complex condition for GPs to manage because we have to see it in two different aspects. One is treating the symptoms as they develop, so breathlessness or lethargy, and trying to help the patient with those. However, there is also the second aspect of heart failure, which is to try and prevent it getting worse. Now, to do this, we have to use several different medications and start at low doses and slowly increase the dose dependent on the patient's tolerance. When we look at the secondary preventive medication used in heart failure, we can see that they are relatively simple drugs. However, each of them needs to be carefully titrated against the patient's condition. So when we're using our ACE inhibitors, we have to watch the blood pressure, making sure we get control, but at the same time, making sure we don't cause hypotensive symptoms. When we use our rate-limiting medication, we're trying to optimise the pulse between a very narrow band of 60 to 70 beats per minute. When we're using our aldosterone antagonists, we're often using them in combination with medication that could cause a potassium to climb. And so again, we have to monitor the patient very carefully to ensure that we've optimised their treatment accordingly. The Enhanced Heart Failure Protocol is embedded into the clinical system so that it's available to the GP at the time of consultation. So when the GP is seeing a patient, they can enter the protocol to assist their management of heart failure while the patient is present. It will take them through easy steps, missing out the stages where the GP and the patient have already achieved optimal control. So if a patient is on an ACE inhibitor and well controlled, that part of the protocol won't be displayed. It will move on to the next step, which is required to make sure the patient is on the best prescription to ensure their ongoing good health. I'm going to demonstrate how the Enhanced Heart Failure Service Protocol works within the consultation. So here we are within the patient record. When I start to record the consultation, we see that the protocol triggers automatically and asks me if this is what I want to do. Of course, I could be consulting the patient for other issues, but on this occasion we say we're working for their heart failure. So I accept that I want to use the protocol. The first thing it asks me to do is what am I doing at the moment? Do I need to record an ECG? Do I need to manage the patient? And I'm going to manage the patient on this occasion. The protocol's first step is to look for ACE inhibitors and for ARBs. It's found that the patient is currently taking an ACE inhibitor, but now wants me to check that the medication is appropriately up-titrated. So I say, yes, I wish to check that, and it takes me to the prescription screen so I can see what medication is being prescribed and what doses the patient is receiving. I know in this chap's case, he's on the maximum tolerated dose, and it's asking me if I would wish to code that so that in future episodes I'm not going to be asked the same question again. Once it has looked at the ACE inhibitor, it will then go on to check that beta blockers or other rate controlling medication is prescribed. Again, it will ask me if I wish to check that the dose is appropriate, and if so, is this the maximum tolerated dose? At that point, the protocol will then look to see if a patient is on an aldosterone antagonist, and in this patient's case, it finds that that's not the case. And so it's asking me whether or not I would wish to prescribe an aldosterone antagonist at this point. It also would allow me to say, actually, the reason this patient's not on that medication is because it's contraindicated. If I wish to initiate, it will take me to the prescription screen. However, on this occasion, we'll say that we don't wish to do that. And it has now checked the blood pressure is optimised, it's checked that the heart rate is optimised, and it's letting me know that I have actually managed this patient appropriately for their heart failure condition. However, what we find is that it also is now checked the nature of the patient's ECG, which is demonstrating that it may be appropriate for the patient to undergo consideration of cardiac resynchronization therapy, so pacemaker and device intervention, and it's offering me the opportunity to have an e-consultation with the local cardiologist to deal with that. In this case, we've had that conversation and the patient doesn't wish to do that, and the protocol terminates with the patient's medication optimised and all possible interventions considered. The enhanced heart failure audit assists a clinician in managing the population seen in general practice by highlighting those patients who are yet to have their medication optimised, not only at the level of just an ACE inhibitor, but to triple therapy to ensure that their heart failure progression is prevented as much as possible. The enhanced heart failure clinical audit also identifies patients who have yet to be coded with a heart failure diagnosis. Now, these were important to the GPs on two levels. First, there is the clinical level to suggest that a patient who is yet to be coded and identified cannot be appropriately managed. The clinical system will not trigger automatically to demonstrate this patient to the GP and the clinical team to allow them to ensure the medicines are optimised. However, on a second level, also important to general practice, is that if our QOF populations aren't appropriately populated, then we will receive less funding per point. So it's quite important that not only do we try to identify patients for their good clinical care, but it also ensures a good clinical management of the general practice budget. The clinical audit identifies patients who are on various levels of intervention. So it shows those patients on ACE inhibitors, rate control medication, or aldosterone antagonists. But more importantly, it shows how they are being used in combination. So it can end up with that list of patients who are most optimised on triple therapy, and also identify those patients who may not be receiving any of the three vital interventions. Within the audit, each therapy group is broken down further. So in the case of the ACE inhibitor, we look at compliance and blood pressure management. In rate control medication, again, compliance is observed as well as heart rate recording and what level the heart rate is achieved. For the aldosterone antagonists, what we do is we again look at compliance, but also ensure the electrolytes are being monitored appropriately and that they are within acceptable range. Within the audit, we also look at heart rhythm, because we know that 1 in 3 patients with heart failure will also be found to have atrial fibrillation, and if this is identified, they should be anticoagulated to also reduce their stroke risk. Increasingly, GPs are being asked to see not only our population as individuals, but as a population of patients with a clinical condition. We can use the audit results generated by Oberoi to show us who is at risk within our general population, to develop task lists, to call patients forward to ensure that their blood pressure is optimised, they're on ACE inhibitors and that is optimised, and their heart rate is controlled also. In this way, the audit and the protocol can be used in conjunction without the patient present to make sure that the clear steps needed to be undertaken are outlined to the GP through administrative work rather than clinical consultation. The enhanced heart failure audit is stored within the System 1 environment and can be found in the normal reporting folders. So into reporting, clinical reporting, and there is the file labelled Oberoi with all the various components outlined so you can see the actual details of the paper audit within the clinical system. And as we know from our reporting within System 1, from this stage you can access the patient lists to ensure that people can be managed en masse, either through lettering, inviting people to attend, or with ensuring the appropriate code to put in their notes. The benchmarking component of the Enhanced Heart Failure Service allows a GP to compare their performance with others, both in their locality and nationally. This is of benefit because not only can we see how well we're managing our individual patients, we can see what can be achieved by comparing ourselves to the best practice there is. Of course, this also exploits the competition within all general practitioners to be the best within the profession and hopefully drive our standards even higher.